So, hello all, welcome to this episode of Conceptual Anesthesia. Today, again, we'll be talking about some critical care MCQs, especially for the upcoming Superspeciality exams. So, we'll be talking about obstetrics, burns, trauma, and oncology. And as usual, I'll be mixing the MCQs so that you can have a flavor of everything. So, when we talk about oncology, when we talk about ICU, a characteristic thing is tumor lysis syndrome. So, which is a hallmark of tumor lysis syndrome? Anybody would like to attempt this? What is the hallmark of tumor lysis syndrome? The correct answer is hyperuricemia. So, tumor lysis syndrome is characterized by hyperuricemia, hyperkalemia, hyperphosphatemia. So, we used to remember the mnemonic UPK, and they were all increased, and hypocalcemia. So, hypocalcemia is the only thing, usually it comes as a choice, but here we had the choice as hyperuricemia. So, they can try to confuse you because you know that there are two, three things that are increased, so they can try and shift them. Remember hyperuricemia, hyperkalemia, and hyperphosphatemia. So why does this happen? Because of rapid cell lysis. So when cell lysis occurs, we know that potassium, phosphate, and uric acid are released. Hypocalcemia occurs secondary to hyperphosphatemia. So that is why hypocalcemia is usually the answer. So this occurs when large number of cancer cells die rapidly, releasing intercellular content such as potassium, phosphate, and nucleic acids, which break down into uric acid into the bloodstreams. This leads to metabolic disturbances, as I told you, hyperkalemia, hyperphosphatemia, and hypocalcemia. And usually it is most commonly seen in hematologic malignancies like leukemia, lymphoma, but can occur in solid tumors. So it is a complication of cell lysis leading from in patients of leukemia and lymphoma. And this is a very common indication of admission to patients to critical care settings. So here we can see again, so these can cause complications leading to AKI and renal failure, and hypocalcemia can lead to numbness, tingling, and muscle spasm. And when we talk about prevention, the most important prevention is to hydrate the patient, and sometimes the patient are also given allopurinol. Rasburicase is also used for treatment along with aggressive IV fluids. Now another second MCQ, a 55-year-old male with metastatic prostate cancer presents with severe back pain, weakness in both legs and urinary retention. So MRI shows compression of spinal cord at the level of T7. So we should note that the prostate cancer can spread to the bones due to metastasis and can lead to severe back pain and can lead to numbness also when it can compress any nerve root. So which is the most appropriate next step of management? So the correct answer is surgical decompression. Okay. So when it causes symptoms like weakness in both the legs, urinary retention, that is the time we think about doing a surgical decompression. So this is the most appropriate first step managing the spinal cord compression due to metastatic prostate cancer, especially when neurological deficits. So as I told you, when there is a neurological deficit like weakness and urinary retention, we think about doing a surgical decompression. The other options can be used, but they are not typically used for bone mets. They can be used for the underlying prostate cancer or certain tumors, but not especially for the bone mets. Here the question is very typical. It asks that the patient is having bone mets and the patient is also having symptoms. So what will you do? So 60-year-old woman with 45% total body surface area burns requires intubation of airway protection due to suspected inhalation injury. The respiratory therapist notes that her PA2 is 65 millimeters of mercury on 100% oxygen. So we should know that here the PF ratio is very less. Usually when we breathe oxygen on 21% oxygen, our PO2 is much more than 65. Okay. So here the PF ratio is very less. The saturation on 100% oxygen should be a lot, around 98%, and the PO2 should be around more than 400 usually, routinely. Here the PO2 is just 65. That means that the patient is having a bit of airway injury or inhalation injury, and that is what is suspected. So which of the following is the most appropriate step? So here we initiate mechanical ventilation and give the patient positive and expiratory pressure. So another thing that we should remember is when we talk about total body surface area of burns, we should remember the rule of 9 given by Wallace. There's a complete talk on burns. So just go through that talk on burns whenever you are free. In burn patients in inhalation injury, the airway and the pulmonary parenchyma can be damaged by heat, smoke, or toxic gases. So usually they'll give you a clue that the patient had burns, had sooty discharge around the lips, the patient had burns in a closed space. So these are the cases in which the airway injuries or airway parenchyma involvement in inhalation injury is much more higher. And this can lead to airway edema, reduced lung compliance, and shunting resulting in hypoxemia. So this patient had hypoxemia. And the best way to manage it is to intubate the patient, start with the positive and expiratory pressure, give high FiO2. PEEP also helps to keep the alveoli open, improving oxygenation by reducing shunting and improving functional residual capacity. It also prevents atelectasis. So we talked about other things also, but inhaled nitric oxide, as I wanted to tell you, it is only useful in patients with pulmonary hypertension. Now coming to a bit of obstetric, which of the below is not a criteria for preeclampsia? So we should be familiar with obstetric patients because one or two MCQs can come, and real life also obstetric patients form a very important subset of patients that are admitted to the critical ill units. Okay, there are complications of obstetrics. Usually the patient is young, not having any previous comorbidities. So that is why they are easily salvageable and can be returning to their normal life very soon as they get better. Which of the below is not a criteria for preeclampsia? So we should know the diagnosis of preeclampsia. The correct answer is 24-hour proteinuria, which should be more than 0.3 gram. So what is preeclampsia? A constellation of hypertension, proteinuria, and organ dysfunction. So remember these things: hypertension, proteinuria, and organ dysfunction. And when the patient has seizures along with that, we call that eclampsia. So when the patient has seizures along with preeclamptic features like hypertension, proteinuria, organ dysfunction, we take it as eclampsia. And the greatest risk of eclampsia is just before delivery to 24 hours after. So you should remember these things. What is preeclampsia? So in the previous MCQ, new onset hypertension, proteinuria. Let us see what are this is the criteria for diagnosis of preeclampsia. So patient is having hypertension. So hypertension is defined here is systolic blood pressure more than 140, diastolic more than 90 on two occasions, at least 4 hours apart after 20 weeks of gestation. So remember all these things, they can be asked in a MCQ. So 140 by 90 on two occasions, 4 hours apart after 20 years of gestation in a previously normotensive patient. And this should be followed by some organ dysfunction. So what do they call as organ dysfunction? Either the patient is having proteinuria, that is more than 0.3 gram in 24-hour urine specimen, a platelet count of less than 1 lakh, a serum creatinine of more than 1.1, liver transaminases at least twice the upper limit of normal concentration, patient has pulmonary edema, or she has cerebral or visual symptoms. So we know that there should be blood pressure and then should be one of the other things. One of them may include proteinuria, platelet count, creatinine, liver transaminases, pulmonary edema, or cerebral or visual symptoms. Now, when we talk about eclampsia, that means that this patient of preeclampsia also has seizures. Okay, so seizures cannot be attributable to any other cause except preeclampsia. And when you have a patient who's seizing, initial management always talk about airway, breathing, and circulation, and then we move to disability. So here also we move to airway, breathing, and circulation. So we have to maintain the airway patency and prevent aspiration. The woman should be rolled onto her left side because the patient may be drowsy and chances of aspiration are there. And on the left side because the patient, if it is pregnant, then it prevents aortocaval decompression, aortocaval compression. So why do we maintain the airway patency and prevent aspiration? We have to prevent the maternal hypoxia. We have to treat the severe hypertension that the patient presents. If she has eclampsia seizures, we have to prevent the recurrence of seizures and evaluate for prompt delivery. So a drug which is used in eclampsia, very typical one is magnesium. So always remember we have to use magnesium when the patient has eclamptic seizures. But whenever you use magnesium, whenever you give a dose of magnesium, remember it's got a narrow therapeutic range. And when the magnesium toxicity occurs